So Babylon go in with a disruptive service. Doing that in the NHS is so much more difficult. The problem was you couldn't say it was better because the evidence didn't exist for the trusts. It's one of my beliefs. You have to do things in the way that they're always done to start and then bring in the disruption later. And we always talked about doing something and it felt like now was the right time. So we founded Pastel Health. The mission and the vision is we want to build a multi-specialty, nationally scaled, NHS-focused outpatient clinic. Two things we want to do are transform patient lives, give clinicians the most fulfilling care experience that we can. Pain is one of the things that drives most healthcare inequalities in the UK. If you can point to a single thing, pain is one of those things. Pain is skewed deprived. Those patients has less ability to advocate for themselves within the NHS and less ability to navigate waiting lists and less ability to navigate the GP even. So those populations are left to suffer in pain. It's a really important thing to us to be widening access and solving healthcare inequalities.
Sam, welcome to Healthtech podcast. How you doing, sir?
Thank you very much. Very good. Thank you. And thank you for having me on.
You're very welcome. Long time listener, first time caller, I believe.
Yes, that's right. That's right.
For the biggest use case of this podcast, I think, which is the old listen to it before an interview to impress the interviewer.
Yes, I've used it many times. Most recently at Aviva.
Nice. Which we'll definitely get into because Mark's a friend and know him well. And you know Umang as well from your time at Babylon. So we got loads to talk about, man. We got loads to talk about.
Yeah, absolutely.
But not least, let's start at the beginning. So you're a medic, right?
Yeah, by background.
What did you do in medicine and what led to you leaving to join all of this health tech nonsense?
I think I was always more interested in the commercial side of healthcare.
Okay.
Right from the very get-go. My dad was a GP, so was often involved in the business side of that, and I helped out on Saturdays at the practice. Nothing to do with the business, from summarising notes and eating takeaways, basically. But that's what got me into medicine, I think, and got me starting to think about it, and was more interested in health tech and that side of it. And I think it's partly to do with the impact you can have as a doctor, and especially as a junior doctor. It's very one-to-one. Just as a junior doctor, obviously that changes as you get more senior in your career. But that was kind of frustrating to me. And obviously the downside of that is you never get the same amount of satisfaction from anything ever as helping a patient. You just can't replace that. But the other parts of it, helping more people, the ability to impact more populations, greater population size, greater number of people across multiple specialties, I was more interested in. And I was always more mathsy. And there isn't much maths in medicine, and I kind of like that and the financial side of things. So that's what drove me to leave. Yeah,
the only maths is in pediatrics, isn't it? Where you're just constantly calculating
body weight and surface area.
Exactly,
and anesthetics a bit.
Anesthetics a bit, to be fair, So how far did you get in medicine?
I did F2.
Okay.
And then left after that.
Yeah.
When I was leaving, the day after we finished F2, I had a kind of moment that was you shouldn't leave.
Right. Shouldn't leave.
I shouldn't, I kind of left the house, was really hungover. It was raining. Because we'd been celebrating finishing F2, stopped raining, rainbow came out, and this lady that I'd been looking after on my previous job for the whole time was walking down the street. I hadn't seen her walk the whole time I'd been there, and she was with 20 of her family. This was right outside my house, and she was there with a son who we'd seen, and her son was crying, saying thank you so much, and I was I should never have left.
Wow.
And so it's kind of driven me to stay in healthcare and been that is a sign I can't leave. But it was that kind of made me second guess it a bit, I guess.
It's so nice to have that feedback loop though.
Yeah, exactly. And that's the thing, it rarely happens. And one of the things we'll talk about later, which we're doing with Pastel, is trying to increase clinician fulfillment. And that feedback loop is part of that. And that story is part of why we're trying to do that.
Yeah, because people have heard it on this podcast before, but this is the one thing that I've said that I do miss, or one of the things that I've said I missed, which is being thanked, first of all. Don't tend to get thanked all day, every day, like you actually did as an anaesthetist or in medicine. But also this transcending everything about how you feel for the good of someone else.
Yeah.
It's so difficult to get that in any other field and any other
Yeah.
specialty. But then to have all of that, all of those things that drove you, out of medicine, which was definitely not the patient care, but all the other stuff. But then having all of that kind of vindicated in this moment of like extreme thanks
Yeah.
outside your house
Yeah.
with a rainbow in the
Yeah.
background
When
with
I was
20
hungover.
family members, whilst
And I was
hungover
weak.
as well. Oh goodness. But thankfully it happened because you obviously stayed in healthcare. So what was the first thing that you did then? What were you looking for outside of medicine, and how did you make the move out?
I wasn't sure what I was looking for. I was looking to work in health tech, and that was what I was looking for, really. And I thought consulting would be a good way to. So I did consulting.
Okay.
I thought consulting would be a good way to transition from medicine and open a lot of doors.
Sure.
So joined a company called Candesic, who I think you know Michelle and, and Len,
absolutely.
maybe Mark, maybe. But yeah, joined them, and I absolutely loved the work they do. It was very, very intense, and kind of just what I needed to kind of like snap me into a new role. And it was like another education for me. They do commercial due diligence and strategy consulting. So looking at private equity companies buying healthcare assets, and we would be the kind of like commercial due diligence of that business.
Okay.
And so you'd see lots of businesses. It was very high turnover, good times, lots of deals happening, lots of work to be done, long hours, weekends, but amazing experience. And like it kind of made me into like what I then became. Like, taught me financial discipline, taught me how to think about businesses, showed me the breadth of stuff that was happening in healthcare across, like we do the deals in life sciences, from care homes through to medical technologies, like all different things. It was really, I can't emphasize enough how an amazing opportunity
Interesting.
it was.
Commercial stuff as well is quite different. In fact, probably like the opposite to clinical care as well.
Yeah.
So I often hear when people talk about the move out of medicine that so much of it is mindset and so much of it is changing the way that you think about things and the way that you see the world almost. It must have been, or you tell me, is it or was it like a shock seeing how much money there is in the system? Because the amount of zeros that you're dealing with, especially at private equity level of businesses buying businesses, you're unlikely to know or to kind of think about that as a clinician even, but then to see it, I don't know, is that a bit daunting? Is that a bit weird? Was it completely reasonable for you? Yeah,
it was very eye-opening to like see what, like how different companies created value and what was happening. Because obviously I didn't have much insight into this before I did it. And so it was a kind of a whirlwind of, it completely changed my perspective and understanding of healthcare in general, because there's so many different ways that different companies fit into the kind of, we would just see the clinician part of it. And so you could imagine what a hospital might sell, like how you might sell a hospital or how you might look at a hospital, but every other aspect of healthcare that contributes on the journey before hospital, after hospital, the things that are used in the hospital. There's such a big value chain extending from all of those areas, which are kind of really eye-opening for me to see. And the work was it was fascinating stuff. And I learned so much there, and I'm very grateful to Michelle for giving me a chance. And
definitely.
And the education, really. And
we're going to talk about you becoming a founder, obviously, but were you thinking about starting your own business even at this point?
Yeah, at that point, on my way to work, I'd be listening to like Healthtech podcasts and like the VC podcast and all the things coming up Stanford and these things. Like that's what I was listening on the way to work.
Are you someone that's always got loads of ideas then, and you're trying to figure out a way to commercialize it, or are you?
Yeah, I think I'm more on the like execution side. Sadly.
Okay. Fine.
Sadly, I can see an opportunity and judge an opportunity, and maybe I'm too harsh on that, which means that I don't have loads of ideas because they're all shut down. But yeah, I think I'm more on that side of it.
Okay. I kind of relate to this because I do have a lot of ideas, but similarly, I shut so many of them down myself. I think because in the spectrum of entrepreneurship, I'm probably quite risk averse.
Yeah.
So I've not raised money because I find that frightening. The fact that you would raise millions on something that may or may not work. I just couldn't do it. Not at this part of my career anyway. But yeah, I also ran accelerators, and when you run accelerators, you just see so many pitch decks, and just as a function of time, you see all of the ones that don't work, which by the way is basically it was literally all of them. Like even Babylon, which we'll talk about, didn't work in the end. So it's like I don't know where those successes are, but thankfully people like yourself are still trying, which is excellent, and we will come to it.
Yeah, it is. I mean, the odds are stacked against you, and you have to be comfortable with it or suffer.
Yeah.
There's two ways, or not do it, I guess, isn't it?
Yeah, absolutely right. Absolutely right. So what's next after Candesic then?
So I joined Babylon with in the NHS team with Paul Bate at the time and Umang later. And
I saw Umang, by the way, on Tuesday. Bumped into him in Weybridge. He was at a loose end. His car was in for an MOT, and he was just wandering the streets of Weybridge where I live. So said, "Do you want to go for a coffee?" And he said, "Yeah, why not? I've got half an hour." And he said to let you know that he taught you everything he knows. So
absolutely true.
I thought I'd definitely get that in on the podcast.
Absolutely true. No, he's a good friend, and I'm very grateful for his counsel and friendship. Yeah, he did teach me a lot, and we worked on some awesome things together.
So it was his team that you were in?
He took over that team.
Okay.
Partway through my time at Babylon.
Okay, fine. So was that the team on GP at hand?
Yeah, we did NHS stuff to start with. So I joined the NHS team, and we looked at GP at hand for the first section of it, and then Paul Bate left to be to eventually be the CEO of Space.
Oh, of course, he came from the CQC, didn't he? And then went to the space
thing. At that point, Umang took over the team. Yeah, at that point, Umang took over the team.
Nice. So GP at hand then, really interesting model that got a lot of criticism.
Yeah,
you're taking the worried well, or not even worried. You're just taking the well, and you're getting all this revenue. They're the ones that don't have chronic disease. They're young. They can use tech, all that sort of stuff. Yeah. How did you guys view it internally?
Yeah, so it's a great question, and it still amazes me how the comms piece on this around what was said about Babylon was never kind of corrected at the time, or never counted really, or never clarified. Potentially.
Yeah.
And that yes, we did sign up loads of young people who wanted to use the digital technology. Yeah. Who, in theory, young people are easier to look after. They're also associated with a lower fee. And they're also so the fee differs per age group and sex. So they were on the lowest fee, and normally this group doesn't use healthcare that much. But the group that we attracted did, because the offer was unlimited GP appointments within minutes, and so they did use it a lot. And so they were very expensive to look after, and they weren't the low cost members of the public. They were high cost because they had lots of appointments. The worried well argument, is very difficult to say. They weren't the young aren't a group with lots of chronic disease, but we did have very complicated patients on the books who we did an excellent job looking after. It's just that's a difficult battleground, that one. And I think ultimately we're offering people a choice. And anyone could have joined it, and those people selected to join it, and they got an amazing service for it. But the unit economics of it was very difficult because of that model of unlimited care.
Let's go into that a little bit then. So the unit economics being difficult, was the goal to make it profitable independently as a service, or was it a loss leader to something else?
Yeah, I think so. It's difficult for me to know. Obviously, these are all my perspectives. Sure. Not being inside the Ali's head and his view. But I think ultimately a service has to be profitable in the long term. There may have been a time where growth at all costs is fine and growing the numbers is good enough. And think about unit economics later, and maybe that was a time when this was okay to do. However, that's not always the case, and eventually these services, they have to wash their own face and be profitable to be sustainable, and to invest in the service to make it better, because that money can't keep coming into a service that's consistently loss making. So yeah, I think it has to be profitable, and I think the struggle there is you can't have a fixed fee and unlimited use, like in a model
Yes.
of primary care. It's very difficult.
Yes.
But I think the evolution, and this is my story of my journey at Babylon, but the evolution of that is, okay, so you're running a GP at hand, a very accessible primary care service. You can try your best to make that profitable. And we did loads of cool stuff there. So I think in a year we overturned gross margin by 100%.
Wow.
Through like a combination of product initiatives, clinical initiatives, head office initiatives.
Where are you making that margin? I mean, you've done a list there, but specifically though,
mm-hmm.
where are the big chunks actually coming from?
So there's a big part on the administrative function, like automating parts of that and deworking the call center and things like that. Big part of it. Scheduling. A big part on running a slick clinical service. And so this is like the basics that actually I love and is so important. And when I was at Candesic, businesses that would sell would be bang on these. Right. It's like, what's your utilization? How do you manage your staff? What can you take out of appointment time? What can you put before?
Interesting. I see.
How can you help clinicians do their job? What can you take out? It's these kind of like metrics and, a big one was skill mix as well. Like, how do you triage people up front and get them to the right clinician, which everyone's doing now. But at the time it was 100% GP when I started. And so that skill mix was a huge thing. And these are actually basic things, but done well, they can make a huge impact.
Got it. And in terms of like the system with GP at hand, because when you're introducing something disruptive, there's obviously the impact on those patients who are getting a better service or unlimited appointments and that kind of thing. But there's obviously sometimes it's a benefit, sometimes it's not to, I guess, the entire system. The knock on to secondary care, for example. So what was the system that GP at hand fitted into, and how did that change?
We were convinced that, the whole thesis of Babylon ultimately was that accessible primary care and high quality primary care and innovative primary care creates net savings to the system. So we were convinced that happened. And then, so there's this benefit that's accruing outside of the system that we're involved in. So the wider NHS is benefiting from these patients not going to A&E. These are all hypotheses, not going to A&E so much. Yeah. These patients' chronic disease being better managed and them not going to not exacerbating as much. Like all of these things that good primary care can do. Yeah. And primary care, good primary care, is obviously the key to unlocking savings in a healthcare system. And so we were looking at ways to find deals where we could do the primary care, and then we could share the savings that were created in the system with the system. And that is essentially value-based care as it's known in the US. They have managed risk populations and they do the primary care, and then they share in the savings from their secondary care spend. That's how most of or a lot of care runs out in the US, and what Babylon eventually did and how Babylon grew in the US. Yes. And Umang and I signed a deal in Wolverhampton that did this.
Because Umang was excited. I remember Umang's excitement about this.
Yeah.
And the reason I remember it is because I grew up in Wolverhampton. Yeah. So it was just very strange hearing Umang talk about Wolverhampton at the time. Because we've been friends a long time. He was my boss in pediatrics. So that's how long I've known Umang, since I was an F2. Yeah. Which is super interesting. But yeah, so what exactly did you set up then in Wolverhampton? So you were taking the primary care of the region.
Yes, Wolverhampton is uniquely set up in that it had 10 at the time practices that the trust owned, so vertically integrated primary care.
Huh. Okay.
But there are a lot more practices in that. So it was about 60 of 300,000 people were in those practices. 300,000 people in Wolverhampton, 60,000 in those practices. And the deal with Babylon was we would implement our technology and services for those 60,000 We'd then measure their costs over time, benchmarked, adjusted for needs, and all these things, the NHS need allocation formula. And if there was a saving in the system, we would share it with the trust. If there was an overspend, we would be accountable for that overspend.
So you were just super transparent about
your
P&L, basically.
Yeah, and it was a really amazing deal, and I really was like very proud of it. We worked so hard to get it done. It's obviously it's Umang's deal. He led it. I was supporting him.
Yeah.
But it was I think the first of its kind, and I think probably the only one that's ever been done in the NHS.
Wow.
That may all change now with the ACO contracts.
Yeah.
That we're talking about now, and so I wish it had more chance to fly, because it could have really shaped this 10-year plan and these ACO contracts.
Do you know what's happened to that since Babylon's obviously gone under? Do you know what did EMED take that over?
No, that contract was ended as the focus turned to the US.
Ah, I see.
So it didn't have a chance to fly, which is really sad. But it's just, I think it was a decision that had to be made, and it's a shame.
God, that could have really changed things in the UK, right?
Yeah, it could have. I believe it. If done well, it could have changed things either way, right? If it was terrible,
true.
If it was terrible, it could have changed things for the worse. It would done well, it could have set the scene for the 10-year plan and for ACOs. But it's all hypothesis now.
So is that opportunity still there then for vertically integrated primary care trusts to buy up practices?
Yeah.
And for some management company, call it, to come and run that primary care?
I think you have to have willingness to spend more on primary care than the budget
in
allows,
order to make the savings.
Yeah, because what's happening right now is everyone is spending the primary care budget on primary care, and that limits what primary care can do.
Yeah.
Whereas if you're saying, okay, and it's a bet, right? Like this is the this is the hard part about it, because you may spend more in the first few years. And so you either need a partner who can absorb that with you, or you need a balance sheet that can absorb that, and you're happy to do that. But so that's why it's so hard to set up with an independent agency. Within the NHS is a bit different, but with an independent agency, that's tricky.
Needs a lot of capital. That's a big raise that's needed, basically. Yeah, okay, I understand. Did you stay at Babylon long after that deal?
Yeah, I worked out in the US from London.
Did you?
Yeah, so back to my Candassic hours, like all night, and so it was really intense, really interesting, completely different worlds.
What were you chasing in the US? What were you?
So I was
part of there?
Thinking about their value-based care strategy. So what interventions do you do for your populations? How does that all add up with your financials? How do you believe there's a saving from doing this intervention in that population? Yeah. And so I was working with a lot of US clinicians, and a lot of the US team was difficult, being in London at the time. All the conversations were happening in America. But it was fascinating work, and like really interesting, like healthcare economics stuff.
Yeah. God, you must have learned loads about the US space.
Yeah, I did.
Is that useful now?
I think some of the thinking is.
Yeah.
Some of the thinking definitely is, and the approaches we took, and the complexity of the problem, solving those type of problems definitely is a helpful thing. And I think, not for what I'm doing now, but maybe in the future, if value-based care becomes a thing in the UK, definitely. 100%. Definitely.
So then Oviva came next. So Mark Jenkins, who's a friend of this podcast, been on a couple of times, I think. Yeah, how was that? It's good timing to go to Oviva, I think.
Yes, it was. So Mark hired me, and Mark hired me into Oviva, and we worked together on just as the GLP-1 boom was starting. Okay, you can call it that. Yeah. I think Saxenda was obviously out in the wild, and Wegovy was just coming through nice approvals, and the world was starting to talk about it. GLP-1s.
Oviva was growing crazy fast as well.
Yeah. And I think partly due to the boom in weight management.
Right.
I mean, it's a shame that we had to wait for the drugs to
Yeah.
come into. I mean, it has materially changed the impact of the effectiveness of the services. But Aviva have been doing that service since 2013. And so it's just been struggling to grow. 3-year waiting lists.
Yeah, of course.
It's just not been prioritized, which is now great to see it get prioritized, but it's had to have these game-changing medications come out to get it prioritized. We call ourselves a preventative healthcare system, but we had obesity there, which we were doing nothing for, which causes all the diseases we spend our money on. So it's great to see, and great to have been a part of it, to get weight management services like accessed by much more people who need them. So really there was amazing time to join. Did a lot of thinking around, do we do self-pay or do we stay NHS? Did a lot of work on how do you make this work in the NHS and how do you then scale that in the NHS? And it's a great success story. To skip to the end, Aviva now has like over doubled the market size and the people who can access these services on the NHS. They have the people coming into the service to talk about advocacy for digital services. Their bottom deciles are overrepresented, which is true like within obesity. So you're getting that like access to those populations. I think we were talking about before, through digital care. The average BMI of people on that program is 47, and the cutoff to get in is 35. So it's like really people. It's not like the fringe getting
it's people
in.
that need it. Yeah,
it's people who you can have the most chance to benefit from that service, like from a health perspective. And it's doing some great things for sick days as well. I'm not sure on the stats, but I think around 35% reduced sick days for people on their program. So like it's a really great example of how digital health and innovative companies can scale in the NHS and transform outcomes and patients' lives.
What was it like going to a company like another startup after Babylon? Did you find the culture the same, different? Like because I've heard so many different things about how Babylon was run and like what it was like in there versus other places. But it's interesting to me that Aviva also being a fast growth VC funded startup that didn't grow as quickly, but is still growing, is still like, I'm just interested in what did you learn about culture there? I guess.
Oh, it was a completely different culture.
Oh wow, completely different.
Completely different. Okay. Yeah. I think my view is affected a bit by the fact I was working in the US for a year.
Okay.
And the culture there was wholly different to the culture of Babylon before I worked in the US.
Right.
It was a lot more commercial and a lot more direct.
Right. Okay.
Than Babylon was before that.
Right.
And Aviva, Aviva's it's grown. Like if you were going to choose how, like in retrospect, how to grow, it's grown through like building evidence and building partnerships with the NHS, and with the NHS as a partner, and it always firmly anchored in that like partner sense. And I think that was always at the core of what Babylon was doing as well, but it wasn't always how that was perceived. And I think that there's a difference in perception, and I think that was like a big difference. If you had something like 80 clinical studies published about their services that like showed the evidence and had really good partnerships with commissioners, and it's just it was a different market. Like the markets Babylon were in, like they were just different how to get into those really innovative ways that they got into those markets. And Aviva's done it in a different way. They've gone in traditional like commissioner relationship build up, and that's like a really hard business to challenge and a hard position to challenge, and it's worthwhile the hard yards that Mark and team did.
It's a heck of a moat.
Yeah,
trying to displace
to get to
where they've got to.
Yeah,
I can remember, this is years ago, when I just left the Digital Health Learning Accelerator. So we're talking 10 years ago probably, or nearly there anyway. But I can remember I saw Mark present at London Business School, and he put up a slide of his NHS partnerships. And bear in mind, the narrative at the time was that, the NHS is very difficult. It's hard to get NHS contracts. And of course it was, and it still is. Mark put this slide up of like all of these NHS logos. And I'm not joking, like people in the room like gasped.
Yeah.
Of like, how on earth, what? Like, how on earth? And then it just gets swamped by all of these people. Like, what on earth is your secret to this?
Yeah. It's hard. It's hard. He did some hard yards, and he did a fantastic job. And now, so Mark's moved on, but it's now led by Martin, who I don't know if you know him, but he's a great guy and has taken the business from strength to strength.
Nice. On to the main course of this conversation, really, Pastel Health. So you're another ex-Babylonian that has started their own company. I don't know what was in the water in that place, like honestly, that you guys have all seen, like what can be done with your own companies or something, or just whether it's just testament to the hiring of Umang, frankly, I don't know. But Pastel Health. Yeah, tell me the whole story, man. So you're living the dream. You got your own startup and you've got a live service. So you've done a lot of hard work to get to where you are already. You also had a lot of like announcements and stuff recently. But tell me, start at the beginning. Let's talk about the whole thing. Yeah.
So I guess the beginning is I've got an amazing co-founder called Krish Patel. He's like we went to medical school together. And so we've known each other for years. We were at Babylon together. So he's another ex-Babylon who started a business.
There's two more.
Nice. Yeah. And he went down a product route after that. So
okay.
Also at Babylon, and after that at GSK, so he started his own women's health platform at GSK Ventures. And we're very complementary in lots of different ways, and I'm super grateful for like him putting up with me, and like for the it's what you need, right? You need someone there to lean on and be there for you. And he really is. And I think moving forwards, we've got like such complementary skill sets to do it. And we always talked about doing something, and it felt like now was the right time. So we founded Pastel Health. The mission and the vision is kind of, we want to build a multi-specialty, nationally scaled, NHS-focused outpatient clinic. And the two things we want to do are transform patient lives and give clinicians the most fulfilling care experience that we can. And that those two things obviously kind of flywheely.
Yes.
And the last one, being in the mission, is like super important to us as ex-doctors. And I think, part of that, like being able to say, like the fulfillment story we talked about earlier, like that fulfillment can mean so many different things. It can obviously mean salary and what you reimburse. It can mean how you feel about work. It can mean the outcomes that you've created and resurfacing those. So it can be like how easy your job is day to day, or how easy your job is made by the person, by the technology. So I think it's really important for us, for that to be front and center for us.
So many questions on this. Let's talk firstly about what exactly this is very, very practically, in terms of what does it mean that you're doing a national multi-specialty NHS outpatient clinic? Like, what does that mean that secondary care hospitals, consultants that have clinics are going to refer to your outpatient? Like, what does this actually mean? Like, is this brick and mortar? Yes. Is this digital?
It's a hybrid model. So we will have brick and mortar, and we do have brick and mortar for our first service, but we'll also be remote. And remote, we have a preference for remote. We're choosing, so that's that part. We'll always be like referred to from a GP.
From a GP, okay.
Yeah, so a GP will refer patients to us. We will provide consultant-led services that are referred to by a GP. Will be a hybrid service, so we'll have some face-to-face brick and mortar facilities. We'll do things like we're doing procedures for our first service, so interventional pain procedures, and we'll do a remote service as well, and we'll lean towards the remote side because obviously it's just preferred, and as we've talked about, how it helps to access different population groups, but can't have it on its own, I think is a good message. So we've got a hybrid model there.
Yeah.
And that's the vision where we are right now. Yeah. We've started with chronic pain. So we are our first service is chronic pain and is live, and we started treating patients, and we chose chronic pain as our first specialty for a number of reasons. One is it has some of the worst waits in the NHS today. Yes. Often you hear a year plus waits for these services. Yes. This drives healthcare inequalities, and pain is one of the things that drives most healthcare inequalities in the UK. If you can point to a single thing, pain is one of those things.
What do you mean by it drives inequalities?
The lack of access to treatment for pain is driving healthcare inequalities. So
got you.
So pain is skewed deprived. The sufferers of pain, chronic pain, skewed deprived, and those patients has less ability to advocate for themselves within the NHS, and less ability to navigate waiting lists, and less ability to navigate the GP even. So those populations are left to suffer in pain, and not being in pain is something you shouldn't have to wait a year for. So it's one of those things where it's a really important thing to us to be widening access and solving healthcare inequalities. So that's one of the reasons we went for pain. I think elsewhere you've got long clinician-facing appointments, long pathways, programs of care. So lots of potential for disruption, and basically none of that's been done so far.
Yeah,
because you've got it's not come in, see us and go.
Yeah,
it's come in, see us and have your pathway of care and go. And there's lots of stuff, all the good stuff we talked about from Babylon, and how Aviva do their weight management programs. So much stuff you can put into the pain management journey.
Yeah.
And then lastly, and really importantly, clinicians in this field are really enthusiastic, and they've got, it's difficult for them to deal with pain patients every day in and out, because they're difficult. They've got difficult problems to solve, and to make their job easier and more fulfilling, I think they're a group who are very receptive to that. So I think it really fit with our mission for that to be the first one.
I love this. So business model wise, it's fascinating because you're basically using everything that you've learned on your career journey, right? From Candesic, understanding the commercials and knowing what drives value, to then at Babylon, the GP at hand thing, knowing that knowing exactly where you can drive that margin increase, so therefore how to really smooth the service out and make it efficient. And then obviously at Aviva, the way that that's been actually practically executed in weight management, all that stuff. It seems that this is the culmination of lots of different things, right? So what can you explain how that is a business for me? So who pays you? Who do you have to pay? What is the business model here, quite practically?
Yeah, so in black and white, we have contracts with ICBs.
Yeah. Oh, nice.
The integrated care boards. We then can accept GP referrals. GPs refer to us. We do a kind of package of care at that point. So we do a really long first assessment. We do, and we're paid as an activity payment by activity model.
Right, yeah, okay.
So, and then we'll do, first appointment, understand the person, understand their life, understand their pain. And that's a really long, deep appointment to really make them feel heard and start co-creating how we're going to...
Very much needed in chronic pain.
Yeah, how we're going to treat them. And then a multidisciplinary care team will then deliver that care. So involving one-to-one psych, one-to-one physio, pain management programs, nursing, medications reviews, interventional pain procedures, and those things in different sequences and different volumes for each patient.
Right.
So you're kind of constructing a care package and then delivering that journey.
Are you subcontracting that, or
we're doing that end to end?
Wow.
Service.
So they're your employees that are doing that?
Yeah.
Interesting.
Yeah,
wow.
So we're providing a healthcare service. And
yes.
That's a full end to end outpatient service, and that's one of the many we have planned.
The idea then obviously being to do that cheaper and better than what the current standard is.
Yeah. Well, this is the thing to come back to,
right?
That I mentioned is so Babylon go in with a disruptive service off the bat, right?
Yeah.
The new service that's not been existed before. And a lot of people do this in healthcare, and doing that in the NHS is so much more difficult than doing a service in the way they, it's already done.
Are used to uncomfortable with
this is how they pay for these services. This is how these services run.
Yeah.
So there isn't actually, and it is actually, I think, the wrong approach to go in and say, here's a new model. It's cheaper and better, because that's what Aviva were doing. And they did, and they came in with a cheaper service with evidence. The problem was you couldn't say it was better because the evidence didn't exist for the trusts. But it was cheaper and had high quality evidence, and still we're not getting commissioned. And
Wow.
it's so difficult to do. And so I think there's an element, and it's one of my beliefs, you have to do things in the way that they're always done to start,
Yes.
and then bring in the disruption later.
Yes.
And so that is our approach. So the business model is super basic. It's nothing. There's no innovative way we're doing it. We're doing it how the NHS is used to it.
Except there is in the clinician fulfillment angle, which I find fascinating, because this issue, dude, like you'll get it as an ex-medic, right? Like the conditions. We talk about it so much, there's no need to go over it. The conditions, we know the conditions, right? It's causing so many people to just think about leaving. It's causing so many people to waste some of their time during the day, a lot of their time probably complaining about things or feeling anxious about things or just like all of the above. And so actually having something that's business model positive for improving the experience of clinicians, I just think is so important. And that's not just a moral argument or an argument based on the fact I'm trying to side with my people as an ex-medic. It's more that people talk about the unsustainability of healthcare for many reasons, but the NHS is stood up so much on people being overworked, and a business can't make margin on people being overworked because the whole thing will just then decay.
Yeah.
And I personally don't see the I don't need to explain it, but staff can leave and you can turn them over and then they'll be fresh and green for a little while, but then they'll undergo the same thing, and that can only happen for a certain amount of time until people stop applying to be doctors, surely. And surely this story that's been playing out, and you kind of feel that maybe is starting to happen now, that it's nowhere near perceived as the career it once was. But finding the business models is so hard. So what have you done there? Are you just assigning it as, no, this is just something that we're doing, it's going to help us with hiring, we're going to sell some of our margin down to increase the fulfillment of staff? Or is this something that you've actually turned into if we do increase fulfillment, we get increases elsewhere, and it is a flywheel?
Yeah, I think it's something we are doing without considering the finance of it, but I think it has a financial benefit in that obviously you have lower churn, you have more effective clinicians per day.
So it's a long arc of realizing that value.
I think that's why it's in the mission. Because if it wasn't in there, those things slip, right? And it's our commitment to clinicians to work with them on that. And it's easy for me to say all this, right? We haven't proven any of this or like done hardly any of it.
Yeah.
But at the stage we're at, it's like signaling our intention to work with clinicians to make this a more fulfilling job. And that more fulfilling is so broad, like we discussed earlier, that we are. Like our intention is to go out and listen and see which bits of those, like how we can increase fulfillment with clinicians, because we want them to come and work for us. There's a very small group of paying clinicians out there. We want them to want to work with us. And so it's just, I think we haven't thought of it from a business perspective.
Yeah.
We haven't crunched the number, which is unusual for me. But it's more of I guess it's part of the passion.
And also probably intuitively, that there's value to be made there.
Yeah.
And that probably is based on your intuition from everything that you've done before and all the skills and knowledge that you've stacked over time.
Yeah.
You probably are quite aware that over a long arc, this is very likely to pay back. It's not an insignificant amount of money something like this will take in terms of upfront capital to get something going that's in part bricks and mortar, in part service. These people, you're doing end to end, so you've got a lot of employment to do with clinicians and all the rest of it. So how much How much does that take to get something like this off the ground, and how was that fundraising journey?
So we're delighted to have closed our first investment round.
Congrats.
Thank you. The Albion Venture Capital led it,
Yeah,
Molly and Christoph from there.
Nice.
And I think we had such nice conversations with them where we were just aligned, and the way we saw the NHS market, and they're investors in Aviva as well.
Yeah.
So they really
good
get it.
point. Yeah.
So they really, really get it. And it was just a really refreshing conversation and, process, and super, they're great. And so it does require a lot of money. It's an undisclosed amount that we've raised. It's a small round. We're super lean at the moment.
Fine.
And maybe, there's lots of, the way we're thinking about it is giving ourselves options.
Yeah.
So we're building to start, and pace is the option. Like, do you want to go faster? You need more money.
Yeah.
Do you, but our key thing, and like one of again, a learning and accumulation of my experiences so far, is to become like break even, cash flow positive as quickly as you possibly can, and then grow from there, rather than grow before, because I think it's just how I prefer, like how I prefer to look at it, and Kush is the same.
But it also sounds obvious, but it wasn't always like this.
Yeah.
Babylon being the perfect example of, when I spoke to Ali on here, that's what he talked about, that back then it wasn't about profit, it was about revenue.
Yeah.
It was just about getting as many customers as you can, and then at some point you can flip into profitability. The problem with it just that relies on capital always being available. Yeah. And that's what he said was their undoing towards the end. And that's his, version of that story of, there just wasn't the capital available when he needed it for that final hurdle. And it's funny because my instinct is always, well, that's what a business is. You spend less than you earn and you make profit.
Yeah.
And it's only when you've got a bigger vision that you're like, no, you need upfront stuff. You need to be loss making for a while. But it's a balance. It's a balance, right?
Yeah.
Because then also, if you say you run this super lean, that's a decision to run it super lean. It's a decision to not raise loads of capital up front, because again, you'll probably crunch these numbers, but the more you raise as well,
exactly,
then you're giving away, and then the valuation.
It's harder to do the exact thing I just said, right? If you've raised, 5 million at the start, you that comes with extreme growth expectations, and then you can't focus on that. Okay, can we make this business work? Do the unit economics work? I mean, they almost don't matter at that stage. Like, you're back in that world where you've got to grow and fulfill this big ambition, and like that, maybe that's the direction we go, but we go there from a position of strength.
Exactly, position of strength, and from being informed that that's exactly what you need, and you have a much better plan of what you would do with it as well. I guess.
Exactly.
Tell me about your co-founder. What are you guys? You said you're very complementary in your skill set. What?
He's handsome.
So he's front of house. What are your roles? Like, what's you versus him? Like, what do you bring together to the table?
I've taken the kind of like commercial side, business development, finance, investor relations type things. Yeah. And marketing. Okay. And he's taken like the big lift, which is like the running the service, HR, operations, these kind of things. People. Which is basically ultimately the product. Yes. And he is people are your product. Yeah, he's indeed a product guy by background. So that's the broad division of things. But we're very close on everything. And I think the division's working quite well. I think as we grow, I think he'll hand over the ops, and then he'll focus more on the product and the technology and the services that we do, more so. But right now, as I said, we're lean, so we're doing everything.
So you're in chronic pain now. Is that in one region? Is that multiple regions? And are you going to increase in chronic pain, or are you going to start to diversify across different specialties?
Yeah, I think this comes down to the funding. I think if we'd raised 5 million, we'd be multiple specialties. Yeah. We are going after one specialty and expanding in pain. Nice. So we've got one live service. We have another one confirmed, not launched yet, probably in the new year. Yeah. And we have a number of other opportunities we're excited about coming around the same time. Uncertain on those. But but hopefully, it's a game of pipeline. You have enough in the pipeline and something will come through. So that's a big part of the time I'm spending right now. And then, I think there's other opportunities coming around. Like there's, as I said, wait lists are bad. So you don't necessarily need to get original contracts in ICBs. You can go to trusts and outsource work. And, there's one of those opportunities at the moment we're looking at. So I think these things will start to develop. We're super early. We went live in October.
Oh, wow. Okay.
So it's really, really new, but really exciting to be live and to have treated patients. It's a really, really cool to see it happen.
It's exciting times, man. Do you see that this is the future, the way that, I mean, obviously you're going to say yes, but is it? And what future does this fit into? How do you view what healthcare is going to become? Because in part, as a founder, you've got to be building for a product that you've got to know what else is changing around you, right? In healthcare, you can't be building completely in isolation, not caring what the advances are everywhere else. I can't believe we got this far without mentioning AI, by the way.
Yeah.
And unfortunately, we might have to mention it now, but feel free not to. It's up to you. But do you understand the question I'm trying to ask? Like really clumsily, like what's the vision of healthcare broadly that this front door fits into? Or say front door, it's the bit after that, isn't it? But the referral into outpatients. But where's healthcare going? Big question.
I think for our services, for our outpatient services, and for the business we're building, I think we have three things that the way we're thinking about it. We have the mission that drives us. So whatever we do to build the business, this is like a preamble to the answer to your question. Whatever we do, does it fulfill our need to transform patient lives? Does it fulfill our need to increase clinician fulfillment? Does it help us scale to more specialties? And does it help us scale nationally? Is it scalable across the different specialties and different places? So that drives us. Then we've got like a second thing, which is do the basics right. And, you can build a good business in, like, there are so many businesses transacting outpatient clinics that have just done the basics right. And I say just, that really underplays it by saying just and by calling it the basics.
I hear you.
But it's like good operations. Like, do you know your numbers? Are you on top of your finances? Have you got your clinics running like good utilization rates? How is the flow through your pathway? Have you managed DNAs appropriately? Like all of this basic stuff, it is not basic in aggregate. And I think the experience of like both at, looking at the private equity business I did and the experience at Babylon has like really drilled that into me, or maybe I drilled it into those two places, to Babylon at least. But that is like a really big lever of like building a good outpatient clinic. It's not disruptive in the sense that this is anything new, but it's just excellent ops. And then the third part is like, this is the disruptive part, and it sadly is AI. So we are going to talk about it. But just, it's like, it's an amazing time to be building a company because so many people are building different use cases for AI all around you that you can use. And the complicated thing around that is anyone can use them. So like, you're not disruptive or different from using it, but how you use it is really important. Where you use it in your business and how you use it to, like, how you use the just any type of AI, any product will differentiate the businesses. And I think to build a competitive advantage, if you've vertically integrated AI to your business, you can change your central cost model. So like your central function, marketing, finance, analytics, like you can run skeleton teams that leverage AI there. So you've got a fundamental cost advantage to other people. Then you can obviously optimize your service, and you can, so far what we've been doing, we've been running with an extremely lean team and AI. I built our website in a weekend on Lovable, watching the Ryder Cup. We do our marketing with AI. We do our analytics through AI. It's like all of these things. Another just boring but concrete example is our policies. We've had to write and think how we're going to run this business, go through like rounds of checks from the CQC and from commissioners. And normally you'd have like a really expert team that does this. But like with AI, you can write, obviously we've written them, but you can write these policies and they all link together AI can like help you make sure you've done all the things in your policies. They all link together correctly. They track the meetings properly. Like there's so much there that we're using it for to like leverage ourselves right now. And it's these exact things, you know, they're not new things, but in aggregate, they transform a operating model.
Yeah.
And so if you've then got a different, speak to me in a few years, see if we've been able to do this, right? But if you've then got a different cost structure, you're able to invest more in services. And ultimately, the way the NHS is going is there's a big part in patient choice. That's like, you know, My Choices and the NHS app. And if you're a brand name of like high quality, excellent service that you can invest in because you've got lower costs than everyone else, then you're going to like, that's how you eventually win that market.
Well, their margin is your opportunity, etc. And the more margin that you've got to play with, the more that you can compete in quality of service and all the rest of it. We think about things so similarly. I completely agree with you, because even when we started SomX, you look at the competitors, particularly the larger, more bloated agencies that just have overheads left, right, and center that aren't built AI native whatsoever. It's so obvious and true that it's similar to what people talk about actually with hospitals in the Middle East, that they're undergoing this leapfrog tendency right now, where they're not built in decaying buildings with, you know, the trope fax machines and all the rest of it, but this infrastructure that they need to consistently improve. And to your point earlier, you know, you have to go into a service and mirror it and sort of be it before you can then improve it. They don't have this issue. You can sort of leapfrog everything. It's the same as companies now that are starting today. I mean, Harry and I have had this conversation, who's producing this. So literally that people can start a company today and leapfrog all the infrastructure of absolutely all their competitors. To exactly your point, then spend the margin down on beating that competition elsewhere on the battlefield, which is ideal. And it's sort of, what you're talking about sort of reminds me of Neko Health as well. That you talk about doing the fundamentals, you call them the basics, but you might say the foundations.
That's a better word.
I mean, but it's true. I mean, I've said this all the time, you know, if we do what we say we're going to do and do it on time, we'll be the best agency on earth. It's literally as simple as that. And I call the same thing, like doing the basics right. But no, it is this group of fundamental foundational activities that when they are done right, you can then sprinkle a bit of good design, good joy, like in various different places. And then all of a sudden you've got this really solid and joyous service. It sort of reminds me of what Neko Health are doing, because I saw someone critiquing it, saying, well, you know, it's not more than you'd get at a GP if you asked for it, and then you did this other thing, and then you did this other thing. You'd be able to get all this for free rather than the couple $100 it costs, or however much it is. But I was looking at it thinking, well, no, that is the point, though, that you don't have to jump through those hoops. You don't have to patch anything together yourself. And then when you go there at the specified time, it does all get done in the moment. The results delivered to you right there, the referrals made, and then you're booked in for the same time next year. So you've got the adherence
and there's
to it.
There's
so
the
it's
experience component of it as well.
Yeah.
There's a prestige with that, right? That have you had this? Like there's that they have as well.
Yeah.
Right now, it's a whole but that's it. Stitching together different parts into a nice journey. It's like good experience, and patients will eventually know about you and come to you for that reason. And hopefully the way the NHS is going, hopefully that becomes through the NHS app. Obviously, very hopeful. That's the way. Hopefully, the things unfold.
Last question, mate. So for patients, then, what is the perfect outpatient experience that you are trying to deliver? So through the patient's eyes now, rather than a system lens or a financial one or anything like that, what's the standard that you're aiming for? What are the goals that you're aiming for those patients specifically?
Yeah, I think in a basic level, we just want them to feel impressed by the service, happy, you know. Yeah, and that's happening, right? It's Kush is on the phones, answering to patients, and is like so nice to them. And I think, you know, it's really like a part of the experience to build that in as we hire and grow.
Sure.
But like they're like, oh, thank you so much, and they're so surprised they've got an appointment so soon, and and then they have it and it's with a really nice clinician who spends the time with them. It's convenient for them because it's remote. It was booked to, I think it's being the stage one is them being impressed with the service. Stage two, I mean, this is like unique to the service as well. So for pain, for example, we want people to feel empowered to manage their pain without us. So we want them to not need us. That's the whole point. Like we give them the skills, the education, the ability to manage relapses and to manage like their pain when they've left the service. That's the whole point. So I think it's very specific to like the service. I think there are some general things, but pain as a specific service, that's the goal.
I love that, man. And listen, I particularly love it, and this is quite timely because we've just come from our team offsite, like our retreat that we were in the outskirts of Bath for a couple of days, and we were having a conversation last night about some NHS services, and we were all talking as patients. Actually, we're talking about our own experience going through certain outpatient style appointments and procedures, and a couple of our staff were talking about their experiences with smear tests, and not to go into the details, but they had really like negative experiences of those for no other reason, really, I think, from listening to the stories, than I think the clinicians were overworked. The clinics themselves weren't run efficiently, and I don't mean efficiently that they didn't have the throughput of stuff. They were trying to get too much throughput through. I think that ended up being
it feeling a bit frantic.
Exactly. And real kind of human factors stuff of trying to get stuff through too quickly just led to some things that caused embarrassment, or things that caused upset, or like all these things that just seemed so easily avoided by getting the incentives right, of getting those staff fulfilled in their jobs, so that, and actually not and as a result of that, then they don't need to push so many people through in a certain amount of time that they get measured on, a blah blah blah, or like whatever it is. But like it's so interesting and timely that this was literally like 12 hours ago that we were having the conversation of the problem that this exact thing solves.
Yeah.
I
think it's
so
important to hire right for that. Hire right, and like that's culture. The fact that those staff are rushed and perhaps not being as personable with patients because they're too rushed or whatever, or the clinic doesn't run well. Like it's good management, good hiring, good culture. And that's easy to do on a small scale. It's hard to do on a big scale.
That's exactly right.
So it's easy for us right now. But yeah, it's something that's so important. And like it links to the mission, right? If we can't transform lives, if patients aren't engaging with us and like, want to be at our service, because there's a lot of DNA rates in pain services are really high. So for our service to feel like something they're getting something good is like, that's going to help us with DNAs as well.
Yeah, definitely. I actually think as well, increasing patient choice is going to help massively with this, because one thing that I did actually say last night was part of the issue seems to be that they can't now say, well, I don't want to go there, I want to go somewhere else, and vote with their feet. That's not a hugely available opportunity for most people in this setting, which is interesting, although it does seem to be coming in. Did you see the announcement about the NHS doing a virtual hospital? And it seemed to be something along these lines. You probably know more about it than I do, but it seemed to be that you would have this kind of ability to spread care across nationally, because you could have a remote appointment with someone somewhere about
these things work. I mean, that I can't comment on the specific virtual hospital thing, but like that model works, because if you don't have that model, then you have like postcode lotteries. You just you can get a remote service here, but you can't get it here. Like it's a postcode lottery, and so you should have these national services, and you should compete for patients based on quality. But it's obviously that's easy to say and hard to manage in practice.
Yeah. Final question, mate. What's one thing that you're particularly excited about with what you're building? Is it like a particular feature or particular thing or just something random? What's the thing you're excited about?
Yeah, good question. I think I'm excited I'm mostly excited to see how the next 9 months goes. Like the next 9 months is so critical for us. It's like, that puts us to a point where we're like, maybe we're ready to raise again. Maybe we need to do much more work. Maybe we've got loads of contracts and too much work to do. Like how the next 9 months unfold, like how services is going, how our patients are giving us feedback, like that. I think in 9 months' time, I just want that right now. I want to see where we've got like what's happened.
Yeah,
like I'm so excited to see what's happened. Obviously, I'm trying to shape it for the favorable, and hope that I've got a hope of what it would be, but yeah, I'm really excited to see how that unfolds.
Awesome, mate. Thank you. This has honestly been awesome, and thanks for coming around. It's nice to do this one at home again.
It's good to be here.
Yeah, it's awesome. But yeah, for people that want to learn more about Pastel Health or about you, or they want to get in touch, what's the best way for them to do so?
Pastel Health's website, www.pastel-health.com, and then on LinkedIn.
Amazing. Appreciate you, man. Thank you.
Thank you very much for having me.